We are on a mission to save and revitalize independent pharmacy.
On the Catalyst Pharmacy podcast, you'll get actionable business advice.
Hear stories from industry leaders.
And share a laugh or two with us.
Fuel your passion for pharmacy.
One conversation at a time.
4,
3,
2,
1. Ignition.
Welcome to the Catalyst Pharmacy Podcast. I am your host, Mark Bivins, VP of Sales at Pioneer X. Today I'm here with Josh.
Hi, I'm Josh Howland, SVP of Clinical Strategy and Development.
Today we're here with Scott Pace, co-owner of Kavanaugh Pharmacy and partner at the Impact Management Group. How you doing, man?
Man, I'm doing good.
Good.
How are y'all doing?
Good.
Josh, what is this on your arm? I see.
He's got a little artwork.
I've got a bruise.
It looks like it. Did you get something new?
No, it's been there 5-6 years.
I don't know. Too long.
It's just
it's there forever at this point.
It is. Yeah. It was just memories of a more impressive youth.
Kudos to you for having an impressive youth.
Look good at the
I didn't say it was impressive. I said it was more impressive.
Those modifiers are important.
Yeah. I recently I work with the Flip the Pharmacy cohort in Arkansas as well. And, Megan Smith does like a weekly office hours. So we jumped on, and I just hired a new pharmacist to cover for my current clinical pharmacist maternity leave. And he happens to be from Arkansas.
Who's that?
Is a guy named Holden Graves. He went
Holden.
to pharmacy school there.
Victoria knows.
Yeah.
Victoria,
So, and that was a weird part. So Victoria was on the office hours and she was asking questions, and Holden happened to be on there and he was her intern. I was like, man, you can't. Pharmacy is the weirdest small place on the planet. Like,
Pretty small group of people.
Yeah.
She said she's ready to take him back when we're.
Dude, Holden's smart. Like, I'm not trying to get rid of him, but the kid is bright.
Yeah.
That's good.
He's
That's
smart
good.
enough to move to Dallas too.
Ouch.
Oh,
Ouch.
man. Yeah.
How'd those Texas football teams
I
do
knew
this
that
year
was
against
coming
the
next,
Razorbacks?
man.
Yeah.
I knew that was coming next.
What am I supposed to say to that, Mark? Of course.
They
agree.
did not do well. My Longhorns looked pretty terrible.
Yeah.
And the funny part was when we watched the Longhorn game, we were like, man, either Texas is really bad or Arkansas is really good. And it turned out that it was a combination of both of those things.
We did not look very good against Georgia this weekend.
Well, I mean, that's
no
like,
one does,
like
though.
it's Georgia though, right? Like that's like playing a middle school team against a college team. It's not going to go well for most people.
Yeah, they're a beast this year. They look like they're Alabama-like.
They do.
So
Yeah.
that's good for them. I'm glad the SEC is having some success this season.
That's sure.
Yeah.
Like, that's a good year.
They never do. It's really a shame. It's been a while since the SEC has been good.
Clearly, it's been a good minute since they've won anything.
Just wait until Oklahoma and Texas join. It'll be great.
I know.
Yeah,
It'll be.
I don't know who was drinking that weekend to make that decision. You're like, come on, guys. Like, now the SEC is going to be what do you call it? The English Premier League.
It'll be the power conference.
Yeah.
I don't know much about English football other than what I have learned from Ted Lasso, so I can't really speak much to
All right.
that.
I don't have an I Believe behind me, but I would.
Right?
But-
I mean, what a great show.
It's so
Got
good.
to the one weird episode this year, but I don't know if you watched that one or not.
I haven't
the dark
seen that one
episode
yet. No, I
With
haven't.
the assistant coach, it was basically all about him.
Oh yeah, Beard After
dang.
Dark. That was
Yeah,
an
it was
interesting.
Was it a dark episode?
So it was after. Are you caught up? Well,
I'm like 5 episodes behind that.
so no, you're not caught
No,
up.
I'm not caught up.
All right. Well, it
I got
comes
like
it comes
5 or
after
6
a
now.
brutal loss, and Beard goes out into the city and does some weird stuff.
All right.
As Beard is prone to do.
He kind of does that.
All right, we probably should actually
Yeah.
start the real thing. I apologize
Okay,
for
no,
digressing into Ted Lasso.
you're good. You're good. We will have to try to work in some UT Arkansas. I'll say this before we leave that. Even if the season ended today, it's a pretty good year. Like, you get to beat both UT and A&M in the same year. That's solid.
Yeah, I mean,
As
and
an
look, we're only
Arkansas
2 wins away from bowl eligibility, and we've got a couple of cupcakes. Well, should be cupcakes in
Right.
front of us, and so I knock on something.
I'm knocking
that's
on
not,
something. Yeah.
Yeah, not fake wood here.
All Right on.
But but it's been a good season. Coach Pittman has gotten us off to a great start, and it kind of feels it's the first season in my son's lifetime, who just turned 10 last week, where he can remember the Razorbacks actually winning, because they haven't for the last decade. So it's it's fun for him.
That's true.
Well, it's funny. So we can actually tie this back to, pharmacy and the podcast a little bit. Mark and I were talking about, when Arkansas brought in this coach, this was a guy who cared about Arkansas. He cares about the school. He had some personal investment to it, and surprise, it shows that he actually cares about the program. They're doing much better than a couple of other dudes who just walked in because it was a D1 job. So, it's kind of surprising that you do better if you actually care about the things you're doing in life. It's mind blowing.
That's a lesson for many industries. I think that's a point well taken, Josh.
For sure. All right. So for those who don't know, this is Scott's second time on our podcast. So, and it was only, I was telling Josh, it was only 10 months ago, I think you were on around that. And this year's been so long. I was like, you would have told me if it was 18 months ago, I would have been, oh, okay, cool.
It feels like it was about 3.5 years ago, to be honest with you.
This has been such a year, right? Like for you guys more than us, probably. So for a real quick recap there, though, Scott's a pharmacist and a lawyer, so I'm going to get my lawyer questions in at the end of this. I've got some pending infractions I need to talk through.
I can't help you with parking tickets. So
No, and then he also co-owns Kavanaugh Pharmacy in Little Rock there with his wife, Ann Pace, and he's the former CEO of Arkansas Pharmacists Association, and now partner at the Impact Management Group. So he was on last time, really right after the 8-0 decision from, probably a few weeks after.
Yeah, it was early January.
Yeah, the 8-0 decision of Rutledge versus PCA, or if I have that backwards, I'm sorry. And kind of that was on the backs of the heels of Act 900 before that. So we have a lot to follow up. You're also one of the first people that kind of went all in on kind of go vaccine efforts, ultra low freezer, the Pfizer kind of being the first one out the gate. Looks like you called right.
Yeah, no, that's right. That's right. We talked a little bit about that in January, about kind of that process of taking a gamble on that, and that certainly helped us get access to that vaccine early. We were one of the first 5 pharmacies in Arkansas to get access to the vaccine, I think, on December 14th. So that feels like about forever and a day ago. But we've gone through more than a few vials of Pfizer vaccine over the last 10 months.
More than a few.
Just a few.
Just a few.
Yeah.
So what's going to happen with the ultra low temperature freezer?
Well, that's a great question. We actually just got 3 new trays of Pfizer vaccine yesterday, so we're still cranking those out with the boosters rolling out. We reopened our vaccine center. At some point, we'll I don't know what we'll do with it. We thought about selling Dippin' Dots, maybe, Josh. Those need to be super cold. And with malls closing, where are people going to go to get their Dippin' Dots?
I love Dippin' Dots.
They've been the ice cream of the future for the last 2 decades.
I really do, though.
Yeah, exactly, right? So they didn't say how far in the future they were going to be, but there you have it. No, I don't know what we're going to do with it. I mean, at this point, we may bronze it and just put it out front as a memento to the vaccine efforts related to COVID. And I wish I had one of these with me, but we did a little memento for our volunteers at the vaccine center. We opened a vaccine center. I think I talked about that on the episode that we did in January. We ran about 30,000 doses of vaccine through our vaccine center from January 2nd through sometime in the middle of June, whenever we closed it down as demand waned. And we kept virtually every empty vial of Pfizer vaccine that we had used. And I had no idea what we were going to do with it. I thought, maybe we'll make something cool out of it. And as we were trying to figure out some nice little trinket to give our volunteers who helped throughout the process, I found a company out of Toronto that would encase just about anything in lucite. So I sent empty vials of Pfizer vaccine across the border to Canada and had them in which that was another story unto itself, by the way, because they had to get through customs and you had to fill the vials with something, otherwise the pressure of the lucite would crush them. But anyway, they got through clean and came back clean. But we made these little 3-inch by 1.5 by 1.5 little mementos that have a vial of Pfizer, empty vial of Pfizer vaccine encased in them, and gave them to each of our volunteers as a memento of thanking them for their help, but is also a sign that they changed 6 people's lives by helping them become protected against COVID. And we got more positive feedback from our volunteers for that little thoughtful gift. I wish I had one sitting here to show you. I don't have one in my office at home.
What is Lucite? What is that? What is that? I don't know what that is.
Just like an epoxy.
It's clear plastic.
Oh, okay, okay, cool. I was
they Han Solo'd them. If you're a Star Wars nerd,
noted.
My Siri just thought I asked it a question.
Maybe she was trying to interject. She was trying to
tell you what Lucite is.
Question.
She was trying. I don't think I said Siri. What is Lucite?
Man, so I can't I really want to get the surveillance video of the custom agent opening the box and look like you're illegally importing COVID vaccine into Canada.
Honestly, we had to put about 2 mils of normal saline. I had to order normal saline just to inject back into these empty vials. And so I wonder what they thought when they opened that and they saw a fluid rattling around in there. For any Mounties watching, it was normal saline, I promise.
I swear. I promise. All right. So lots kind of change. I'd like to just kind of talk through with you, let you kind of talk about, that we were on the cusp of vaccines really ramping up the last time we talked to you. You were doing a ton of testing already before that. Kind of what's changed in the pharmacy. I know you guys are doing monoclonal antibodies. You've got boosters. You've got this flu/COVID test coming out. I don't know if it's already out, but can you talk through a little bit kind of what's different now?
Yeah, well, I think the big thing that was different for us is, like I told you, we had our vaccine center from January through June, that we were able to kind of offload that large volume of vaccines out of the pharmacy. And from June up until a week and a half ago, when we reopened the vaccine center to handle boosters, we had to re-onboard, if you will, all that vaccine back into our normal pharmacy workflow, which still had the testing that was going on, although at a much lower volume, plus our normal pharmacy business. And so that was a little bit of a challenge for us to adjust our workflow yet again to bring that back in house. We also had to adjust to not having the volunteers to assist or the other pharmacists that we had hired full time to run the vaccine center. It was just a challenge, just to change the positioning of it. And then from a safety operational perspective, but also from a services expansion, we started offering Moderna and J&J, which we really didn't do at the vaccine center. We were pretty much Pfizer exclusively. So, that changed our online scheduling process, having multiple different vaccines, differentiating first or second. But we also used it as an opportunity to do home visits that we weren't able to really do before. So multiple times a week, we'll have one of our pharmacists go out to patients' homes. We try to bundle 2 or 3 family members at the same time. But typically, we did one last week where, a 95-year-old patient who had been in the hospital for a cardiac issue, never been vaccinated, needed to get vaccinated. And once they were home and stable, had a family member call and we got out there and got that patient taken care of and 2 of their family members. So, it's freed us up a little bit too, as the volume has decreased, to be able to do other services related to the COVID vaccines. And then, as you mentioned, monoclonal antibodies, Mark, we jumped on that. We certainly weren't the first jumping on that. One of my colleagues in Central Arkansas, Blake Torres in Benton. I don't know if y'all know Blake or not. He has Westside Pharmacy and several other stores. They jumped in head first and were doing the infusion of the Region Cove as the first store in the state, and just did a great job with that. We jumped in and started doing the subcutaneous monoclonal antibodies. And I wouldn't say that we've had just a massive response to that. There's a lot of providers in our area that are doing that, but it's made an important difference in the health of the people that have gotten it and not progressed into more serious COVID. Many of those who have been unvaccinated. So that's also been a really fun new addition to our offerings. And what's so fun about that in our state is that we tried to figure out how pharmacists could initiate that therapy, prescribe that without having to get a physician's order or to work under sort of collaborative arrangement. And Josh, you mentioned at the beginning how small the state of Arkansas is. Well, I talk with John Vinson, who's the CEO of the Arkansas Pharmacists Association, all the time, and John Kirtley, who is the head of our board of pharmacy. And the three of us had been, bantering about for several weeks about the monoclonal antibodies and how to get us to be able to prescribe it. And it just so happened that they'd been working on an angle. And I was at the health department one day for another meeting and stopped in to say hi to our state's head epidemiologist before I left. And I asked her what I could help her with. And she said, help us figure out how to unlock this monoclonal antibody issue. And so we just sat there kind of, shooting the bull for a little bit. And I said, well, Dr. Dillahay, the real challenge here is that pharmacists need to be able to have the prescriptive authority to do this. And I don't think our law allows it right now. And she goes, well, it's just an immunization. She goes, vaccines are active immunity and immunizations are passive immunity. And it was like a light bulb went on over my head. And I said, well, I've never really thought of the differentiation between vaccines and immunizations. But now that you mention that, our Pharmacy Practice Act statute clearly breaks out vaccines as being separate from immunizations. And she goes, really? And I said, yeah. And I said, it's vaccines, immunizations under the authority phrase. And she said, well, if that's the case, she goes, an immunization is passive immunity. We're giving people the antibodies that they would otherwise create themselves through this Regen Cove. And she goes, let me talk to some people internally. And I said, well, I'll talk to Vincent at the association and Kirtley at the Board of Pharmacy. Let's see if we can't, solve this puppy here. And so I talked to the association and the board, and they were like, that's great. We've been trying to figure out an angle, and Dr. Dillahay may have unlocked this. And she talked to the people within the health department, and then the board and the health department talked. And within about 48 hours, we had a decision from the Department of Health that, in fact, Regen Cove is an immunization, just one that provides passive immunity. And the Board of Pharmacy agreed with that interpretation. And in, two blinks of an eye, it seems, pharmacists had the ability to prescribe under existing statutory authority in our state, all because we've got this great close-knit community of folks who talk and know folks and can think outside the box. And that's, how all of a sudden pharmacists could prescribe that before the federal government came out with their proclamation giving us the authority to do so. So that's been kind of an exciting thing this last 6 weeks too. That just kind of was a happenstance thing that worked out with our association and board and Department of Health.
I feel like somebody should have mic dropped and the epidemiologist should have said, boom, lawyered.
She is awesome, by the way. Dr. Dillahay she's one of the most meek personalities you could ever hope to meet, but she is as sincere as the day is long, has worked her tail off for the last, 2 years, in a bureaucratic role. Mm-hmm. And I don't mean that in a pejorative sense, but I just mean,
right.
That's just kind of where she is. She's been recognized by our state pharmacy association for her dedication to the profession of pharmacy. I mean, cool. She's really been very, very inclusive, and was one of the big advocates for, pharmacists being the frontline providers of the immunizations at the onset of the immunization push, in December and January. So we're really, really fortunate to have her leadership at the Department of Health.
Yeah, that's super cool. Like, I would have never made that leap.
Right. It didn't cross my mind either. I was trying to figure out how to make it work within certain exemptions and getting the Board of Pharmacy and the medical board to work together, or getting the governor to issue an executive order. And in one just kind of happenstance sentence where she said, well, it's basically just an immunization that just provides passive immunity. It's like, if LED bulbs could go on in, 0.8 of a second or whatever, or faster. That's what happened. And then it's like, blink, light bulb. Oh, wow. And we started going forward with it and got it to authority in a couple of days. And that's because of the great folks at the board and the association and the Department of Health. So that was good stuff.
No kidding. That's quick too. A couple of days. Like,
it just kind of goes to show you that, like, when there's a real impetus to do something, it can be done fairly quickly. When it's it might have toiled for months with debate and committees, and you're just like a bunch of people wanting to do the same thing. Like, yeah, that makes sense. Let's do it.
Yeah, and we had a physician in the legislature, a guy named Dr. Lee Johnson, who was very supportive of that. He's an ER doc who saw what was happening in the hospitals around the state and understood the need. The State Hospital Association, at the time we had this huge Delta uptick in Arkansas, like a lot of the other part of the country is having right now. And our hospitals were full. We didn't have emergency room, ICU beds available in the state, and they were just begging for help. And so it was the perfect place for not just pharmacies, and pharmacists, but physicians' clinics who hadn't offered those types of services before to really expand their offering and take care of people and preserve access to our hospitals for not just COVID patients, but all the other patients that needed access to those facilities. So to me, that's going to be one of my favorite memories out of this last couple of years is something like that happening through collaboration, because that's really at the end of the day what the policymaking process should be about.
Right.
So I kind of want to go on the other side of that for a minute. We're seeing a lot of healthcare worker burnout, nurses and doctors and pharmacists. You look on any social media, and pharmacists who work retail right now are probably the most unhappy they've ever been. So how's your staff doing? Well,
thanks for asking about that first. I mean, they're burnt out, man. I mean, I don't know how to say that any other way. They're tired. My wife, chief among them, being tired. We have certainly taken some vacations over this summer. And it's like the first day back from the vacation, it's like you can just almost feel the walls collapsing down around
Pressure
you
kind of
very
higher.
very quickly. And part of that reason is that obviously they're working long hours. They're doing very important work, and patients are, they're scared and want to be taken care of and want to get access to a vaccine. And in those early days of the vaccine, when the supply was limited, it was a little bit of, Hunger Games there. It was zero sum at the beginning, right? It's not necessarily that way now, but if I get one, you don't. That was kind of how it was in January and February and March, and that was stressful. And then you flash forward to what's happened the last, 4 to 6 weeks, with the Biden administration saying, hey, boosters are going to be available starting September 20th. And then all of a sudden September 20th gets here and we're not close to boosters yet. And all that does is increase the noise in the pharmacy with phone calls and people looking to us to have answers and having to reset their expectations based upon something they heard on the news. And that's been a real challenge to deal with, on top of still filling prescriptions correctly and timely and taking care of, the sick kid who walked in the door and being empathetic and taking the time with them and still running a business and still managing your staff, still looking for staff in a time when hiring is, and we can talk about that in a second if you want to, that's super difficult. So I think all of those stressors have really weighed heavily, not just on the pharmacist, but on the techs and the clerks and the delivery people. It's tough. We've actually talked about having some social outings with our staff here in the next month or so, just kind of as a team building. But people are tired. We've bonused our people a lot over the last 18 months, just as a show of appreciation, because we know they're working themselves to death, and I think they appreciate it. I don't know how else to show them appreciation. I don't know if a massage or something like that would be appropriate, but they can at least go out and spend what we've given them from time to time, and we just think that's appropriate to recognize their hard work. So it doesn't change the fact, though, Josh, that they're still tired, and there doesn't seem to be an end in sight. We closed that vaccine center, like I was telling you, in June. And in July, we took a vacation the first part of July. And while we were gone, we got a phone call from our pharmacist who was running the shop while we were gone, saying, hey, the testing has really gone up this week. The Delta variant seems to be a lot more prevalent than we thought it was going to be in Arkansas. And from, the time we were on vacation and we got back the next week, our testing business was almost 50 to 60% what it was last fall whenever we were at our peak of testing. Wow. So it's like we just had enough time to get our head above water after the vaccines had slowed down to turn around, and testing had ramped back up. And as testing started going back down, the boosters were approved, and we reopened the vaccine center, and the monoclonal antibodies are happening. And that's not just us, by the way. That's every
for sure.
every location in the country, independent and chain. And I'll tell you what, I feel bad for our chain brethren who are also being asked to do the same type of work, but are doing it with much less staff than the independents are having to face it with. And so I know that burnout has got to be at high levels, because a lot of my friends who work for chains just tell me how exhausted and done they are, for lack of a better word.
Yeah. I was in a store that was similar to that the other day, and just walked through, and I always kind of walk by the pharmacy just to see what's going on, and they looked like zombies back there, all three of them. Like, in this particular pharmacy it is close to Halloween. Do you think that had anything to do with it? Yeah, well, this one is the chain that has the phone that talks to you and tells you how many calls are in queue. And it was a nightmare. I walked by in like 2 seconds, and I was like, this is horrible. I wouldn't be able to do it.
Well, my wife had to call a fun 3-letter chain a couple of weeks ago to get a transfer, and she was on hold for 45 minutes. And the pharmacist picked up and said, "Hi, how can I help you? What do you need?" And she's like, "I need three transfers, please." And she's like, "You're gonna have to call back later. I don't have time for this."
Oh, wow.
And so, I mean, and certainly that's frustrating on our end, but I can't even imagine what it's like on the other end of that phone. Having worked for chains early in my career, I mean, those metrics are different. The stress is different. Frankly, the expectation of the customer is different too. You know, patients are very friendly and generally pretty accommodating with us in the independent store, but I think their mindset is different when they perceive that they're dealing with corporate America. Their tolerance isn't as much. I don't know. It's a different type of pharmacy practice.
And I think they don't necessarily, like, unless they really know that person, they just see you as another person that's like a nameless, faceless person, almost to a degree sometimes. Yeah. Especially if you don't interact a lot with that pharmacist or whatever, right? Like, I was just in there a couple, like in your experience too, I was just observing. I was like, what are they doing? Like, she's just getting reamed, right? Yeah. She's just getting reamed. She's getting beat up to death, and you could tell she had to go take a minute before she could talk to me. And I was like, okay, all right, well, but yeah, it's so. Speaking of, you kind of talked about staff and staffing. I want to talk about kind of labor force stuff just in general, but before that, like, what was it like getting your staff on board with, hey, we're going to do this monoclonal antibodies, we're going to have COVID positive folks, and can you explain a little bit what that was like?
Yeah, well, it's actually a really good question. So we reopened our vaccine center space to do the monoclonal antibodies, because we were really sensitive to not wanting to purposely bring COVID positive patients into the pharmacy space around normal everyday patients. Right. So we brought our pharmacist who had run our vaccine center for us back on board to do monoclonal antibodies. We opened up a certain number of hours each day. And we set up space with basically 3 theater-style chairs for monoclonal antibodies, because these patients are going to be there for 60 to 90 minutes. We wanted them to be comfortable. We also wanted to be able to lay somebody flat in case somebody had a vagal reaction and felt like they were going to pass out after 4 injections. And so we put medical screens up between each of the chairs. We had an air purifier that we put back there. We tried to do everything we could to make it as safe of an area as possible. We, got a little higher level of personal protective equipment in place. And we actually hired a new person who was a former nurse who had retired and wanted to get back in the workforce. So we hired her as a tech, actually. And that was one of the questions that we just were very straight up with. Are you comfortable working around, COVID positive patients? So long as number one, we'll make sure you're vaccinated, but number two, we want to make sure that we have the right equipment in place for you so that you feel protected. People have been pretty accommodating to what patients' needs are as much as what their own safety is, which is, I think, that's really reassuring. We've certainly gloves, certainly gowns, certainly N95 respirators, face shields, anything that we think will help keep them safe, we make available to that staff who are working around the COVID patients. and they're comfortable with it. We haven't had, knock on wood, any exposure from fluids or other than the nominal close contact that you have while you're injecting people with those subcutaneous injections. I've done some of them myself, just because if I'm asking people to do it, I want to make sure that I'm out there willing to understand what it's like for them to do it. And it's, I think being vaccinated makes me feel not necessarily invincible, but it makes me feel a lot more comfortable putting myself in that position. And we've had good success with that. Billing for all that stuff is a different story altogether, but at least getting the labor force, out there and doing it has been just fine. And we've been very careful, by the way, to segregate. Our vaccine center is reopened now in that same space. So we segregate the time of when we do those versus when we open it up for the general public coming in for boosters, so that we have adequate time to clean. We keep that area at the back, certainly off limits to the people coming in for boosters, even though it's been cleaned. We try to do whatever we can to mitigate any sort of unintended exposure.
Right. So actually interesting. So between the last time we talked and now, my family and I have all got vaccinated as soon as we could. My daughter just turned 4, so we're still waiting on her. And then, was it July, August?
For
when my in-laws came and
no, I think that was like late August.
Yeah. So in any case, my in-laws came and they were supposed to be wearing masks when they were out because they were of the type of people who were choosing not to get immunized. And they clearly didn't, and they came back and they exposed my wife, myself, my daughter, their mother, actually both my mother-in-law's mom, my father-in-law's parents, and then my sister-in-law's now husband. So 3 of the 5 of them got COVID after being vaccinated. They all got a rough cold for a couple of days, but my in-laws actually got admitted to the hospital, and my mother-in-law spent 5 days in the ICU. And it was just like, man, if you ever needed actual in front of your face proof that these vaccines really do work well, I've got literal firsthand exposure that's true. And it was crazy. My wife spent 3 days sick, bounced right back, no problem. My mother-in-law's still on oxygen.
Oh my gosh.
It's crazy.
Well, I think at this point, we're what feels like 9.5 years into the pandemic.
Doesn't
but
it,
I know, right? It feels like
So
that. But
does.
at the very least, we're not too shy of 2 years, 18, 19 months at this point. If you're not someone who knows a close personal friend or family member who has not just had the disease, but had some really bad course of the disease and how it's impacted them, the long haulers are really becoming more prevalent, and it's kind of scary to think of what the long-term impact of having COVID is. I've got a friend who's in the healthcare industry in Little Rock, whose brother just had a double lung transplant after a terrible bout with COVID. He probably should have died several times, and if he hadn't had good advocates on his side, probably wouldn't have gotten into the position he was to be able to get lung transplants. One of my good friends from growing up and guy I graduated from high school with got COVID at the end of June and was hospitalized on the 30th of June. I put on a ventilator on the 14th of July and died on the 24th or 25th of July. And 45-year-old guy who otherwise was healthy, former military guy, just not vaccinated. And those stories are really hard for me to swallow. And personally, I respect people's right to do what they want to do with their health, but I also really struggle to know what's the data point that pushes you over the edge to go, I don't want that to be me.
Right.
I don't want that burden on my family. I don't want that burden on society. I don't understand that thinking personally. And I struggle with that.
Yeah, I'm in the same boat. I would feel insanely guilty if I didn't get vaccinated, got COVID. And if I died and that was my fault, right? I chose not to do it. But if I infected someone else and they died, I couldn't imagine the amount of guilt that you would carry around with that.
Or if you died and your 4-year-old daughter is left behind because you made that decision. I mean, it's not just about self, and that's before you even talk about the economics of someone going into the hospital and occupying an ER bed or going into the ICU and the countless tax dollars that'll be spent on your care. The bed that you're taking when that heart attack patient came in and couldn't find a bed in the ICU or whatever it happens to be. And look, I know people have deeply held beliefs, and I'm not here trying to profess those. I'm just telling you I have a hard time understanding that point of view, and I have a hard time wrapping my head around self over society. Maybe that's the Rotarian in me that truly believes in that service over self mentality. But I think that's really hard to wrap my mind around.
Same.
I didn't mean to get deep there.
Yeah,
Josh.
I know.
Oh,
Mark,
right.
lighten this thing up.
Whew, let's come back a little bit. I was going to get back into kind of, you said you trying to hire. Yeah, that's the one thing. I went to the Kansas Pharmacy Association. Great turnout there. And I think Josh was just got back from Pennsylvania's as well. Mm-hmm. And one common thread. Now, one person I met was fairly immune to it, but almost everybody I met was struggling with staffing, trying to hire. Can you just kind of talk through a little bit of what you're seeing out in your kind of your marketplace or your group of folks you collaborate with?
Yeah, well, I think first of all, the number of people that want to work right now, for whatever reason, seems to be really low. The workforce is just a smaller pot of people right now than we're used to it having, and I don't know if that's because of lingering unemployment benefits. I don't know if people have saved up money and don't want to be working at all. I don't know what the reason behind that is, and I don't think anybody has cracked that nut yet. But I will tell you that the overall economics of the workforce has changed dramatically over the last 2 years, regardless of the number of people in it. In Central Arkansas, we had a Costco open, which is the first Costco in the state of Arkansas, and they've got a higher than the current minimum wage starting wage for their people. So which is great for the folks that are working there, but it has an effect of kind of reestablishing a benchmark.
Your baseline gets reset.
For those lower wage earners. So I think that's an issue. You've got, fast food restaurants that are struggling to hire people that have increased their wages, and frankly are starting to offer some sign-on incentives, if you can believe it. I was up in the northwest part of Arkansas in the Fayetteville area.
You said a sign-on incentive for
fast food.
A fast food restaurant?
Yeah, I was driving down College Avenue in Fayetteville, up where the University of Arkansas is, about a week and a half ago, and I was driving towards campus, and McDonald's on College had it didn't say 99-cent Big Mac or whatever on their sign out front. It said $500 signing bonus. For McDonald's, and I know there are some nursing home facilities in that part of the state that are offering a $2,500 sign-on bonus and are offering really really nice hourly wages for their folks. So, I mean, we're just in a different world when it comes to the economics of hiring, and I say that because it's caused us to reevaluate. Okay, well, if we need a delivery driver, maybe it's not maybe it's not a $11 or $12 an hour person. I mean, maybe we have to be at $14 or $15 an hour. And if that's the case, what does that do to our overall, staffing needs in the pharmacy? Can we absorb that cost? Is that something that we have to trim hours elsewhere? So that's a challenge. And then frankly, it's finding people that you want to have come work in your pharmacy is the next challenge. So, when you've got a place where there aren't a lot of people in the job pool to begin with, the ones that are there with all these jobs that are out there, you have to ask yourself, why haven't you found a job yet? Or why have people not hired you yet? And so you have to be a little more critical with what you're considering hiring. Now, we've been fortunate. I told you we hired that retired nurse, but we also had a job posting out there for several weeks. And we had, a handful of applicants, and they were good applicants, don't get me wrong. But it wasn't the 20 that we would have had, 2 years ago. It was a handful. And we also hired a new, clerk billing tech who just happens to be a college student whose schedule, she's going to school 2 days a week for school. So she's taking 15 hours, but doing it 2 days a week. So she's working the days that she's off, and she wants to pursue a career in pharmacy. So those kind of fall in your lap, but they're not necessarily the easiest ones to find. So it's been a real challenge, and our story's not unique. I bet everybody's in that same boat right now.
Well, I mean, we're not really out of that boat either.
Yeah,
we're in Dallas, and initially there was like, do people want to work? What's going on? And Texas kind of led the charge in YOLOing the cutting the early unemployment benefits. So that's been gone, and it didn't really affect people coming into the workforce at all. And we were talking to one of the recruiters trying to hire a software developer, and they basically told us, 2 years ago you'd put out an ad for a software developer and you'd get 20 applicants. You had you could walk them through, hey, you're going to interview with this group of people. Then a couple of days later, you're going to interview with this group of people. And then, then you have some time to deliberate and go. And she was like, the world's changed now. So you're going to get like 3 applications. You're going to do an interview on the day of, and if you don't make an offer that day, that person won't be available the next day. It's just it's a wild, like,
arranged marriage.
It's like asking somebody to get married during the date, right? You don't even get to go on the first date. You're like,
I think
this
that
is your
show's
guy.
on FX now.
I wouldn't be surprised at all.
FX does has I would say
they've got those kind of shady shows.
They do. Yeah, for sure.
90-second fiance.
But I think that's right. And even pharmacists, I was talking to a hospital pharmacy manager up in the northern part of the state about 2 weeks ago, and I just asked him, how his staffing was, and he said they're down a couple of pharmacist positions, and they're used to being flooded with applications over the last 3 or 4 years. And he said, while they still have 8 or 10, he commented that they may not be the right fit for the job of the 8 or 10 that are available. So they're trying to sometimes fit square pegs in round holes just to be able to have enough staff to support their clinical needs. So that's it's a challenge across the board, and I don't know what the solution is, because I'm with you, Josh. I think it was easy to blame it on the unemployment benefits initially, but Arkansas was also one of those states that earlier than others cut off the unemployment benefits because they thought that was having the drain on the available job force. But that it has not shown to be the case. And in fact, the head of our state chamber of commerce testified in front of the state legislature last week that there are approximately 70,000 open positions in Arkansas right now. Now that seemed like a ton of jobs.
It seems like a huge number. Yeah.
Yeah, I thought so too.
Yeah.
And one thing that's where pharmacy's different. You're right. You don't get to just set your price for everything. You know what I mean? You can't just go, okay, cool, I got to pay everybody $3 more an hour. Okay, I'm going to make sure I get reimbursed better, right?
That's right.
Unfortunately, in this industry, you can't just dial that in, right?
Yeah, it's crazy. Like, I got an email from the place who cuts my hair, and they were like, hey, wages have gone up, so effective next time, all of our haircuts will go up by $3. And I was like, yeah, that makes sense. But you're right. Like, you can't do that. You can't charge $3 more per copay.
No, not at all. And in fact, I do lectures at the UAMS College of Pharmacy. I haven't in the last year and a half during COVID. They've done a lot of these virtual, but I do an economics lesson. And one of the first things I tell them is that while you may think of community pharmacy as a traditional buy low, sell high retail business, half of that equation doesn't really exist for community pharmacy. The sell side of buy low, sell high doesn't really exist. So you've really got to maximize your efficiencies. You've got to make sure your cost of goods are being obtained at the lowest possible cost. And you've got to really get your workflow as finely tuned as humanly possible and getting everybody working in sync. And that's not always the easiest thing, especially when you can't find people.
Yeah, for sure. All right. So I'll go into kind of, I wanted to ask you, because I know you guys were one of the first few to adopt, like, hey, we're going to do an appointment-based model, put it on our website. I remember last time you talked and you're like, hey, you put out testing appointments and thinking, I haven't talked about this on social media at all. And all of a sudden they're just all taken up. That was, sounds like 9 years ago, but, has that bled through into anything else, like appointment based? Is it kind of bled into other areas of your business to try to kind of like, we're all kind of hoping that a little bit of that is here to stay, right? In an appointment based model.
Yeah. So all of our point of care testing now, even outside of the COVID testing, is all appointment based. So our flu, our strep, we do a combo flu COVID that I'm sure others do as well. Plus COVID antigen, COVID PCR, COVID antibodies, all of those are appointment based for us. And that really opened the door whenever we started in June or July of last year with the COVID testing to the scheduling. And while we have not gone that way with flu vaccine, this year, most of the patients that reach out to us about flu shots now are starting to ask, do we need an appointment? And so we have been really, slow on our uptake of wanting to schedule appointments, because to the workflow point, that does create one other piece of workflow. If somebody schedules an appointment, that also creates an expectation that when 1:15 gets here and Miss Jones walks in, that you've got all of her paperwork ready, you've got your label printed, and that you're ready to go. And frankly, we've just been overwhelmed enough between our testing and our vaccines for COVID to make sure we've got all of those in place and operationalized and ready to go to add flu into the mix. And so, are we going to get there? Yeah, we're going to get there. We just haven't rolled it out this season.
Yeah.
Yeah, right. Well, hey, so, Mark, you were asking about, I'll segue here. Mark, you were asking about scheduling. And I do want to give, Pioneer and Josh some props for earlier this year. Josh convened a group of three Pioneer users from around the country, an Arkansan, a Texan, and a Pennsylvanian, to all come together and talk about what we needed around vaccines and testing as it related to the Pioneer ecosystem. And so what that resulted in was feedback being given that the immunization screen now pops up with the ability to input lot and expiration date and save those until they're changed or until the next day. And many of those eligibility check features on that screen, a lot of the bulk patient uploading process. Josh, I know I'm leaving a bunch of stuff out, but that didn't happen just because Pioneer knew exactly what needed to be happened. I give you guys kudos for just having an informal focus group come together and say, hey, we hear that there's issues that we can help you guys solve, help us understand those issues. And so those processes have really made the huge amounts of immunizations that we've been billing and other pharmacies around the country have been billing so much easier than it would have been otherwise, reporting to the immunization registries, et cetera. And so just a big thanks to you, Josh, and your team for being willing to listen and then being willing to implement in such a timely way.
Hey, it was our pleasure. I'm glad we could help get it. I will say I haven't seen a 3 a.m. email from you, Mark, or Rannon in months. Yep. So, I feel pretty good about that, actually.
Yeah, early on, you were certainly getting that because there was lots of opportunity for improvement. And whenever you're, again, back to the workflow conversation, whenever your workflow has been this for so long, and all of a sudden, instead of doing 30 vaccines a day in your normal flu shot day, or 50, whatever it happens to be, and you're doing 300, and there are 95% new patients to your pharmacy, and so you're trying to input patient profile, find insurance information, do all that stuff. It was taking 7 and 8 minutes per person to add a new patient, process a claim, and you multiply that by 200, 250 people a day, and all of a sudden you have really made your day that much harder and longer. So appreciate everything y'all done to help with that.
So the nice thing that'll actually come out of that and is live now, we actually were able to take that bulk uploader and put a become a patient where you can put on your webpage, and a patient can go through and enter all their information, and that'll flow directly into Pioneer now. And then we rolled out a couple of beta locations on the scheduler. Obviously, we tried to go people who were a little bit slower than you on.
Yeah.
I don't want to beta test the scheduler with 30,000 vaccines, so we slowed that down a little bit.
I would not have been your beta tester anyway.
Yeah,
We have a
Come talk to me
process
when
that
it's
is
big.
working at the moment.
Yeah, no,
so
I didn't even think
not
to ask.
anxious to change that, but thank you for that.
So next year for flu shots, though,
Yeah.
we should be pretty dialed in.
Excellent. I mean, I think this is what's great about the last 18 months, as perverse as that sounds, is that I think all of us are looking at pharmacy completely different than we did in January or February of 2020. I mean, I think we've seen where revenue can be generated from that's not necessarily putting pills in a bottle. I think that's exciting.
Yes.
You know, I worked in our store on Saturday morning, and I did 6 or 8 immunizations, which were a combination of flu and COVID, before I filled my first traditional prescription. And those were the first people that came in the door. They were looking for those clinical services. Now, whether or not that is a long-term sustainable thing, I think that's yet to be determined. But I do think it's gotten patients thinking different about who we are and what we do. I think it's gotten us thinking differently about, you know, what we're capable of doing and how we're able to stretch ourselves and do things different, which comes to, are we in the right space? It comes to, you know, what other needs do we have from a billing perspective? All those questions that we haven't been forced to even address, I think, are really coming to light now. And that's a good thing, because that's going to challenge our businesses to grow, expand, get better, become more efficient. And I couldn't be more excited about that part of the last year and a half.
Yeah, for sure. I think you said it last, right? Necessity is one of those things, one of those cool sayings, right? There you go.
Invention.
There you go. There you go. That's what
I told you I use that all the time.
Yeah, no, it was one of those, I guess, time frames. You can't even say a year, 18 months, that really just made people do something different. It really did, and it's been fun to watch. Like as bad as it's been kind of cool to see everyone tackle something a little differently.
And to more importantly, to know that you can do it once you got out there and did it.
Yeah.
And I think that's what that fear of not knowing that you can do it, I think, has stopped people for years from being willing to try something new and almost being forced into a corner to do it because your patients are demanding it and society needs it. Is kind of affirming to know, after all the years of doing things the same way, I can do something different, or I can add something new. And it's hard, and there are challenges, but there's reward to it as well. And I think patients are happier than ever humanly possible with their independent community pharmacist after the last year and a half, because every step of everything we have done has been for them. And they recognize that, and they appreciate it. I think the healthcare team sees what we have done, the physicians, the hospitals, et cetera. And I think they are appreciative and couldn't be happier with what we've done. And overall, I think even the payers appreciate that. If we hadn't been there as independent pharmacists, then the cracks would have been huge that patients would have fallen through. And when you look at communities all across the country, the groups that stepped up and really pulled a lot of these communities through the early days of the immunizations, they were the independent pharmacies. And but for us, what would have happened? And I think that's a great message that we all should take pride in.
Yeah, especially when you're talking about reaching the most vulnerable, the most accessible. That's why I think it's here to stay to a degree. Like, I think people enjoyed or relied on a accessible healthcare provider that you couldn't get into anywhere else almost.
Yeah, I think that's right. You couldn't get into in a lot of places. And yet we were still open our doors late at night. We were still coming to a pharmacy on Sunday. We were still, meeting people at a pharmacy to do a test or to, drive to their house to do a vaccination or whatever it is. I mean, that's the beauty of what we are as independent pharmacy owners.
Yeah, I think the one thing that was surprising to me was watching a lot of rural communities and the ability to really promote public health in a way that hadn't been done before in a pharmacy, or at least hadn't really been publicized well before. So I think when you go back and look at what the effects on public health in the future, there are, campaigns around social determinants of health, and there's campaigns around all these other things, but nobody really thought about how fast we needed to push that down into the pharmacies, because they're the ones in the communities. And, even historically, when, an independent pharmacy went out of business in a community, the collective shrug of everybody else in the state was kind of like, meh. But now I think you're going to look at it and say, man, if this independent pharmacy disappears from this community, the community as a whole is worse. And so I think we have evidence now that you can go out and say, hey, these pharmacies have to exist. You have to pay them a living wage to dispense the drugs and provide the services. And maybe it means that you have to pay them more for being in a rural area than you would pay, in an urban or a suburban affluent area. So I think you have different, avenues to approach why it's super important to have that pharmacy on the street corner, more now than we ever have before.
Absolutely, and don't forget. I know it's the easy thing to say, rural area, because that's what a lot of policymakers think of. But
Right.
don't forget the study that came out over the spring and summer about the pharmacy deserts in the south side of Chicago area.
Yeah.
I mean that is as urban as it gets, and yet
Right.
because of the same kind of broken economic model, where we're going to force you to put pills in the bottle as cheap as humanly possible. A lot of those are in the managed Medicaid spaces in particular, have closed and aren't there. And, going 3 miles in a city may be just as difficult as going, 20 miles in a rural area. And so I think pharmacy accessibility, period, is really critical to keeping people healthy. And our health plans need to understand that. The PBMs need to understand that. And really the policymakers need to fully understand that.
Right. Yeah, that's huge. You're right. It's not rural, it's pharmacy deserts.
Yeah, that's right.
There was a big one that kind of came out where a pharmacy had closed. I think it was a Walgreens had closed in an area of Oakland where that was the only place that was available. And it just destroyed that community. They had no ability to get to a pharmacy at all, and there were no other ones on the bus line. It's completely nuts.
No, it's crazy, and it's the same thing from a health perspective is true about grocery stores and other non-cheap, highly processed fast food in a lot of these areas. Whenever inexpensive and easily accessible food disappears, your health expenses and your bad outcomes go up. I mean, if all that's left is a Taco Bell on your corner or a McDonald's, it's not going to be good outcomes. In the same way is true when there's no pharmacy in those areas. So we've got to be really cognizant of that we are not just important to healthcare, we are vital to healthcare, and it's I think the pandemic has helped to demonstrate that.
So you're going to open up a grocery store now?
Yeah.
Have no desire to open up a grocery store.
You don't want to
Some
open
people-
up another small margin business?
Yeah.
No. Well, I'm working on that, but not another grocery store.
In the grocery store. Nice. So I want to kind of talk through a little bit about kind of an update, so obviously Supreme Court threw out PCMA's case basically against, versus Rutledge and the Act 900 in Arkansas. I wanted to know if there was an update from how that's kind of being enforced. Cause really I think what Act 900 was about, Scott, obviously, you know it way better than me, but it was around having a clear path to resolve anything like paying, I'm going to just say generally payments below cost and things like that. So is there been any more efforts around PCMAs to have a different angle to try to attack it, or has it kind of been okay? We've finally got some wins in enforcing what we set out to do originally.
Yeah, well, remember the upshot of Rutledge versus PCMA was about whether or not the states had the ability to write laws that impacted pharmacy pricing in those self-funded plans. So the ERISA plan. So that was really the upshot was yes, states can do that. So I think what you've seen since the last time we visited is a number of states take a swing at doing that. My home state of Arkansas, the State Pharmacist Association, John Vincent and his crew amended our PBM licensure law that we passed in 2018 so that PBMs that work for self-funded plans are now required to be licensed in the state of Arkansas. And that includes a whole hodgepodge of pricing provisions, which is important. A lot of other states have filed similar bills this year. I don't know that I have seen any others that have passed that directly impact those self-funded plans, but I know that there have been at least a dozen that have been filed this year. From an enforcement perspective, just yesterday, I was talking to John Vincent at the State Pharmacist Association, and we were talking about a consent order that OptumRx entered into with the Arkansas Insurance Department over the summer, where they were essentially fined $50,000 for violating the ban on effective rates in the state of Arkansas, and they had to submit a notice of corrective action to the state insurance department on how they were going to begin complying and making those pharmacies whole. And so John and I haven't talked today to see if there was any upshot to that. But I mean, I think it's encouraging when you see regulators not just recognizing that there are laws, but taking actions to enforce those laws, holding those PBMs accountable, and making sure that such violations don't happen again. That's what it's going to take to continue to level the playing field. And I'm encouraged that we're starting to see more and more of that happen. You've had other states pass bills this past year. I know one of our neighboring states, Tennessee, has passed a new PBM bill. I know Alabama passed a new PBM bill.
Right.
I mean, I could go over a whole bunch of them. I know Minnesota has been looking at language. Wisconsin's been looking at language. Michigan has a pretty aggressive bill that's been filed that I think is going to be later this fall come back up to some more discussion. So I think we're really seeing the momentum from Rutledge v. PCMA continue to roll. And more importantly, I think we're seeing momentum from the state of Ohio and the state of Mississippi and the state of Illinois and the state of Arkansas having these settlements with Centene and their PBMs for the bad acts that they have done. I mean, our Attorney General Leslie Rutledge just last week announced a $15 million settlement against Centene for basically artificially inflating prices in state Medicaid programs. Illinois had a similar announcement the same day, and of course, like I mentioned, Ohio and Mississippi have already had settlements against them for similar activity. So, I mean, I think the momentum continues to be there. Just remember, process, not a destination on all sorts of these legal and legislative activities.
No, that's so true. There's no ever spike in the football and you're done, I guess.
No, you can smile. Just remember that they're always looking for the next loophole, and we gotta remember it's a game of whack-a-mole. So you need 3 mallets in your hand, not just the one from the Chuck E. Cheese.
Yes, agreed.
You know, and hopefully the focus doesn't go away off of this, because it seems like it's one of the very few things right now that seem to have pretty wide bipartisan support across the country, where everything else is polarized. It seems like the one unifying thing is everyone's hatred of a PBM.
I think there's a lot of distrust for the industry right now, and I think they brought a lot of that on themselves, and so that's good for us to be able to shine a light on it.
Yeah, and I think the pandemic's lended itself to how important keeping independent pharmacy, I guess stable or whatever. I think that's also helped put a spotlight on making sure we can't let this fail, right?
Yeah, that's right. I think we are an indispensable piece of the healthcare system, and you let us go away, and you can't get us back. Yeah. I mean, it's just not. You can't let that happen.
Scott, man, it was great to have you on.
Yeah, it's my pleasure, guys.
Thank you for watching the Catalyst Pharmacy Podcast.
If you enjoyed today's episode,
please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.